Leadership Series program. My name is Sue Janzak, and I'm the Director of Marketing here at Health Integrated. And I'm joined today by Don Shivers and Paulina Valdez, also of our marketing team, to host today's event on delivering mandated models of care. We've all heard the numbers. 9 million individuals and growing comprise the SNP and dual eligible population. These are vulnerable, chronically ill, and among the highest need, costliest members in the United States healthcare system. Enrolling these individuals into carefully designed models of care, particularly SNPs, has provided one of the most successful means of effectively supporting these individuals. By focusing on duals, health plans can improve the quality of care, reduce costs, especially for dual-related acute care, and meet state and federal compliance standards, or as we like to see, meeting the triple aim, +2 being the compliance and revenue optimization. So today, we're delighted to welcome Fred Davis, the Director of the SNP program here at Health Integrated, to lead our webinar and talk about the strategy behind developing and enhancing SNP and other model of care programs in order to deliver exceptional outcomes, mitigate risks, and manage health plan costs, all while meeting the evolving CMS and NCQA regulatory requirements at the same time. And a little bit of background about Fred. As the Director of our SNP program delivery, Fred has played a chief role in creating and managing the model of care for special needs program. This has included establishing and implementing policies and procedures to meet the compliance standards of regulatory entities as well as our business partners. Fred is an innovative thought leader with more than 20 years of experience in call center leadership, resource planning, project and program management within the healthcare and telecommunications industries. With his strong customer focus, he particularly excels at risk mitigation, using innovative and creative solutions, orchestrating complex business and regulatory environments, superior negotiation skills, and leveraging best practices in management, coaching, and problem resolution to achieve his goals. Before we get started, just a couple of housekeeping items. We are recording today's presentation, and we'll upload both the audio and PowerPoint to our website by tomorrow. We will also send you an email letting you know when that audio is available online at healthintegrated.com. To facilitate our presentation, all of our attendees have joined us on mute, but of course we welcome and look forward to your questions, and we will allow plenty of time to answer them. Please feel free to submit your questions through the chat box function throughout the webinar. We will collect them and answer them following Fred's presentation. Should time run out before we're able to answer all of your questions, we will respond to each of the remaining questions individually through a follow-up email. And with that, I'd like to turn over the presentation to Fred to get us started. Fred?
All right, thank you, Sue. Appreciate that, and I appreciate everyone joining today. So the focus of today's webinar is to review delivering service for a model of care in today's ever-changing environment. We will review compliance, the different levels of delivery, and the expected results. When we think about compliance, there are numerous factors that come into play. There are the regulatory ones like CMS and NCQA. Then there are the contractual ones based on submission of a model of care. And if you use a vendor, the contractual ones between the vendor and the health plan. To ensure compliance, you will need to have in place quality adherence, audit processes, both regulatory and internal, designated training programs, specific policies and procedures for all aspects of the service model, a structure of specific and documented structure of the plan, appropriate staffing with the appropriate licensure, and of course reporting to demonstrate all that is being done. Now with the model of care, CMS is the overarching governing agency for the model of care. They have established 10 distinct categories defining the end-to-end requirements from definitions to submission requirements and all the way through quality. Within these 10 categories is 90.0 model of care. The model of care has 13 subcategories. It is typically this category that a health plan will delegate responsibility to a vendor. However, rarely is the entire model of care delegated, as most vendors are only able to accommodate portions of the model of care and not the end-to-end product. Model of care is a very high-level description of the core structure, and CMS works with NCQA to define requirements and to audit for compliance. NCQA plays a pivotal role in guiding how service is delivered. They publish a rulebook annually that provides guidance and minimum requirements for each of the 6 structure and process measures that they will look for when they conduct audits and certification of compliance. It is imperative to stay current on the expectations as they do change throughout the year. While each of the measures are vital to the success of the program, SNP 1, care management, and SNP 4, care transitions, are where programs spend the majority of time. Although NCQA does provide very specific areas of measure, they are flexible in timeframes associated with completing many of the requirements. This allows the plan or the vendor to establish their own timeframes, which essentially have an impact on results, staffing, and cost. For example, depending on the size of your SNP population, you may want to establish different timeframes for outreach. If you have a large population, having a very short time frame, such as member-provider outreach within 1 business day, will have a significant impact to your staffing needs in order to consistently meet that criteria. However, if you extended that to 2 or 3 business days, it allows flexibility in how much staff is required. For 2013, there are a few significant changes to the structure and process measures. Within SNP 1, most of it changed from a focus on complex case management to a focus on care management. The purpose of this is to provide a greater focus on the majority of membership versus the typically smaller population that meets the needs of complex case management. Questions you'll need to ask when reviewing this measure are, how does the program need to be modified to provide a broader focus? What licensure requirements exist? And do we need to increase staff, and if so, at what level? Another significant change is regarding SNP 4, care transitions. Outpatient ambulatory care surgery centers were added to the list of care settings. This change makes perfect sense as the focus changes from complex case management to care management, as we can expect to see more impactful program results by following members and guiding them through even outpatient services. This does, however, mean that there will be an increased workload for the care managers and will impact how many members they can effectively follow. This change also will require changes in reporting and collecting of information. Previously, we could rely on the inpatient census to identify transitions. Now there needs to be a better connection with the UM team to ensure that care managers are being notified timely of the new outpatient requests and are able to make contact with the members. Applications to CMS to participate in a SNP model of care program require submission by a health plan. This is required initially upon renewal or any time there will be a change to the original submission or request to expand the service area. The process for a submission can be lengthy and time-consuming as there are specific formats required for this. Health Integrated has had great success in partnering with health plans to write their submissions. Once the initial submission is submitted and approved, the program can become operational. However, if there are any changes to the program, the plan would need to submit these revisions for approval. Another type of submission would be if the plan would like to expand its current scope or to a larger audience. Moving on to quality adherence, ensuring compliance with CMS and NCQA requires a significant focus on quality. There needs to be several triggers in place to ensure timeframes are consistently met, results are reportable, and there is improvement in the health of the member. Health Integrated's quality team focuses on ensuring the policies and procedures capture all the specified requirements. In addition, we also have teams that continually monitor turnaround times for compliance as well as standard chart audits. The best way to ensure compliance is to have a system that is configurable to build in workflows and turnaround times. For example, as we began gathering requirements for a new care management system, we documented each of the CMS and NCQA deliverables, including turnaround times, to ensure the system would be able to have reporting capabilities for each measurement, as well as automated workflows to avoid any missed turnaround times required. Regarding auditing, auditing is imperative and is done at several levels and frequencies. There are internal audits that monitor and measure turnaround times and accuracy, as well as compliance audits by NCQA or CMS. In order to maintain servicing the special needs population, health plans must undergo at minimum an annual NCQA audit and pass with each category. NCQA does provide in advance what the minimum scores are for each category, as well as examples as to what can be submitted to satisfy the requirement. These audits require a significant amount of data to be provided, which can be very challenging for a health plan. Having a vendor manage this process alleviates the significant amount of work for the health plan, since this is typically the core function of the vendor. The NCQA audits are performed annually and are typically completed by submitting evidence to NCQA versus on-site audits. Plans are notified in advance with what needs to be submitted and are also provided an audit tool for tracking the evidence. The audit has specific requirements and is handled on a scoring basis. For example, Section 1, Element A may have 7 distinct factors. However, if 6 are satisfied by the submission, that would be considered pass. NCQA does provide annual training to review any changes to the requirements, and this can be extremely helpful. For example, audits for the prior year, the focus was on identifying members for complex case management, access to case management, frequency of member identification, providing members with information, and education of providers. All of these elements have been removed for the 2013 audit period. Complex case management does still exist. However, it is not a core aspect of the SNP program. When necessary, the care manager can refer to complex case management, and once that qualifying episode is complete, the care manager in SNP continues following the member. Plans must be flexible to meet these significant changes and ensure the programs and systems can quickly adjust. Internal audits and analysis is also a vital contributor to the NCQA audit process. Detailed reports that are reviewed monthly and annually by the SNP management team are required in order to keep the program on track. Minimally, NCQA looks for at least one recommendation for improvement per year based on analysis of performance. Regarding training, one of the required elements of a model of care is to provide evidence of an annual training for all plan employees on the model of care. The training program must include specific information, always be updated, and it must be completed by all annually. As a delegated vendor, Health Integrated is also required to conduct this training. We have it built into computer-based training systems, which allow us to track and report on all that have attended, as well as quiz for comprehension. Another big portion of the program is based on policies and procedures. The policies and procedures are key to providing consistent and documented guidelines for the program. Each one has to be fully vetted by the clinical and quality teams. We also have ours reviewed by an NCQA consultant to ensure our PMPs are capturing all CMS and NCQA requirements and to ensure they are current. This is also where we establish timeframes. For example, regarding transition of care, the requirement is to contact the member post-discharge and complete a discharge assessment within the designated time frame. The policy and procedure for transition of care would specify what that designated time frame is and would read, the care manager will make 2 attempts to contact the member within 2 business days after discharge in order to complete a discharge assessment. Once that policy and procedure has been approved, it will be what NCQA bases the audit criteria on. To ensure there is an assessment completed within 2 business days post-discharge, or that at least 2 attempts were made and the outcome of those attempts are documented. The general structure of the model of care is comprised of the 6 related categories of HRA, which is a health risk assessment, stratification, interdisciplinary care team, care plans, transitions in care, and complex case management. The first being the health risk assessment. This is an initial and annual assessment that must be approved through the initial submission process, and any changes to it will also need to be approved. The purpose of the health risk assessment is to engage the member and have them complete this assessment from their perspective. Once completed, the results are analyzed and are included in the stratification process. The care manager will also use this assessment to help determine what the member's individual problems and barriers are based on how they completed this assessment. Oftentimes, there are several factors that need to be taken into consideration, such as what the state of mind of the member was at the time they completed the assessment, their understanding of their condition, as well as their understanding of the questions. It is important to follow up with a member and to complete a care coordination assessment based on data available from claims history and the member's health risk assessment. This will allow the care manager to properly assess the member needs, their barriers, and to set goals with the member. For example, there may be a question on the HRA that asks, have you felt depressed or sad in the last 30 days? The member may respond yes, which may indicate several potential risks. However, when speaking with the member, it may have been a very situational event and not something that would require further intervention. The next step is stratification. The stratification process is how a member's risk level is determined. This is initially an automated process that combines the following data: claim or encounter data, hospital discharge data, pharmacy, lab results, data collected through the utilization management process, if applicable, data supplied by the member or caregiver, if applicable, and data supplied by practitioners. There are also algorithms and formulas that are applied to this data, and a risk level is established, either low, medium, or high. This process is completed initially upon receipt of a completed HRA, or if one isn't received, it is completed within 90 days of enrollment into the program. The process is then run monthly on the entire membership to help identify, based on current data, if there is a change to the member's risk level, which may require additional outreach or intervention of the care manager. The care manager may also determine that a change to risk level is warranted based on their clinical expertise. This would be presented to the interdisciplinary care team, and if approved, would be documented and appropriate changes would be made. Another very vital piece to a successful SNP program is staffing. Understanding who can do what is key to ensuring smooth workflows and efficiency. It is imperative to understand licensure by state as to what the scope of an individual's license will allow. There are distinct differences based on care management, case management, and complex case management. This understanding also has an impact on who is required to participate in the interdisciplinary care team meetings. Part of the submission requirements, as well as what will be audited, is the actual structure of the organization as it relates to the model of care. The roles must be well-defined and within the job descriptions. Various types of roles within a SNP team can range from non-clinical through medical director. Their contributions and expectations must also be clearly defined. Areas that will be subject to review and audit are to ensure there isn't overstepping of responsibilities. For example, a lot of what is done throughout the care management process is the collection of data. Who can actually participate in collecting that data has an impact to, when you're setting your budgets, what levels of staff will you need. This is something that is ideally handled by a non-clinical person. They are not using any of the data they collect to analyze any information. They're not completing assessments. They're just collecting data. A non-clinical person may also be used to help schedule follow-up appointments with the provider post-discharge. There's a number of things non-clinical personnel can do within the program and still have it in compliance. The key to that is to ensure that what that non-clinical person is doing does not breach any licensure requirements. Also, using an LPN or LMHC to collect and analyze data is an option versus using a registered nurse. Those options are available, again, making sure that everybody is working within their licensure, and that can vary by state. Another portion of SNP programs are the care plans. Care plans are the conduit of the entire process. These are created within the first 90 days of enrollment and are updated and modified throughout the year based on several different triggers. They are used to engage the member and the PCP to review and to provide feedback for the interdisciplinary care team meetings. They also provide an admitting facility with a current snapshot of the member's overall current status, and helps to keep the PCP updated during transitions of care for a member. The care plans are initially created based on the health risk assessment results, if any, and any recent claim or pharmacy data is available. Upon speaking with a member, additional details will be added to the care plan, as well as establishing short and long-term goals. Also captured are any interventions and barriers to the goals, as well as the measurements to complete the goals. Once the care plan is drafted, it is sent to the member and PCP for their review and addition of any details. The care plan is then presented to the interdisciplinary team for review. Based on the current information, if there needs to be a change in risk level, the interdisciplinary care team will make that change at the time. This brings us to our interdisciplinary care team. This team can be comprised of a clinical case manager, care coordinator, outreach coordinator, physician, medical director, program director, other healthcare professionals, the member or the beneficiary, and the member's usual treating practitioner. The team meets on a weekly or as-needed basis to review the following information: the initial, ongoing, and annual member health risk assessment data, summary of care plans for members in levels 1, 2, or 3, also care plans of level 3 members or high-risk members, unplanned admission data, emergency department data, stratification level reviews and changes, members with changes, updates in health status and or new health needs, members at risk for transition, and any other information that has been presented that would cause a change in the member's health status. All the meeting notes included are those in attendance. Any recommendations are documented in the member's file as well as maintained in an ICT log. With regards to the interdisciplinary care team, there is also flexibility in who participates in these care teams. Typically, for a low or medium risk member, an RN needs to be the highest ranking licensure within that care team, which allows only the higher risk members to require the need of a physician to participate in the meetings. This will help coordinate your scheduling of your physician as far as their participation, and also will help save some resources if you break it out in that manner. Another key part of the care team is to try to incorporate the member or the member's usual practitioner in these meetings. They are always invited and encouraged to attend. However, if they do decide to attend, that could create some scheduling challenges with the interdisciplinary care team, because you need to coordinate to ensure that that member participates only when that member's records are being reviewed. It's definitely not an impossibility, but it is something to take into account. But again, it is very encouraged to have that member or provider participate. Transitions in care. Care transitions can be identified from internal or external departments. It could also be established by member self-reporting or any notification from any other provider or caregiver. Once notified, the care manager updates the care plan for the member and sends it to the admitting facility and PCP within 1 business day. Now, we had touched on before that for the most part, NCQA does not have any mandated time frames. They just require that you establish a time frame. This is the one exception to that. When it comes to the transitions, NCQA does require that 1 business day requirement. So you do need to supply the updated care plan to the receiving hospital or setting within 1 business day of notification. Upon transition home from an inpatient stay, the care manager will outreach the member with a designated time frame to complete a discharge assessment. The care manager will attempt to reach the member no less than 2 times during the specified time period. Intervention as soon after a discharge home provides the most significant impact to readmission, thus aids in reducing costs and positively impacting the care of the member. During the discharge assessment, the care manager assists the member with understanding discharge instructions, medication reconciliation, home health, community resources, follow-up practitioner appointments, reviewing any additional potential at-risk scenarios in the home, etc. The leadership team should also be tracking and analyzing all transition data monthly to identify any at-risk members of future unplanned transitions and directing the care managers to intervene as needed. One other category within the program is complex case management. As mentioned earlier, there was a change in the focus where SNP Element 1 was fully based on complex case management. That has moved to care management. However, there is still place for complex case management within the program. Complex case management differs slightly than a member that is deemed high risk. There are specific triggers or transitions that would identify a member as needing complex case management. Members that are determined to benefit from complex case management are assigned to an RN or LCSW for the period of time needed until the member is able to be stratified to a lower level of care. Within complex case management, the member is in contact with their case manager more frequently at the lower risk levels, and the complex case manager is charged with higher level coordination of services. The care coordination and care plans presented to the interdisciplinary care team will also include the participation of a medical director and a physician. There are several levels of delivery within a SNP program. And the program or the plan can determine exactly how they will deliver that service to their SNP population as long as it is NCQA and CMS compliant. There are several ways a plan can determine the level of effort, how it defines its timeframes in the policies and procedures, how they design their health risk assessment, and how they determine their stratification formula. Once this is all determined, then the factor of member participation comes into play. Plans typically expect to see around a 40% engagement rate. Within that, you may have members that are willing to participate, however, just not at a high rate. For example, there may be a member that is evaluated to have a high risk level. However, upon contact with the member, they request not to be contacted again. At that point, the member would be assigned a participation level of low, which will reduce the frequency of contacts. Overall, if a plan is looking to introduce a minimally compliant SNP program, they can do this. However, they should expect to see a low level of return on investment. However, this could be a good way to introduce yourself to the SNP population as you expand your footprint. Plans can also choose to have a high-touch plan. This will have significant staffing requirements to meet the demand of having shorter time frames and frequent touches. However, you can expect to see a greater impact on the overall claim experience and member satisfaction in a shorter period of time. Or you can choose to be in the middle. Any way that a plan goes, delivering service to the special needs population will have an overall impact to their quality of life. When we take a close look at our SNP program, we quickly determined that there isn't a one-size-fits-all approach. This challenged us to identify ways to structure our product to offer 3 different levels of service. This allows our customers to select a plan that meets their budget and quickly implement a compliant program. For example, our basic program is minimally compliant program that has extended time frames for outreach, lower overall membership population targets, and would be the least expensive route to implement. This would allow a plan to enter the market and be able to build on their offerings over time. This approach would be great for plans that want to start small. In contrast, the richest plan provides for significant member participation level, touches, and interventions. This plan would provide the highest return on investment. The slide on the screen shows how a tiered plan can be structured. For example, on the basic plan, you may have your target or your goal may be to only reach 30% of your population. As far as the folks that you don't reach with your initial health risk assessment, you may decide not to do any additional outreach attempts. As far as the interdisciplinary care team, you may want to use an RN for all levels and physicians only for complex case management. When there's a transition of care, you may want to only use 2 attempts within, say, 10 business days. You'd also want to target to only have up to a maximum of 2% of your population in a complex case management. And your caseloads per care manager would be fairly high. It would be about 150 or above, depending on your overall population. A middle tier plan would target about 35% of your overall participation. You could outreach an additional 2 attempts on your initial participation for HRA, which will give you a higher level of participation after the initial outreach. Again, for interdisciplinary care, you'd still only use an RN for all levels, except for complex case management, you'll use a physician there. For transition, you may have more attempts in a shorter time frame. Again, remember, the quicker you outreach a member and get contact with them, the better your risk of lowering your readmission rates. And a high-touch plan might include having up to 45% participation, which would require extensive research to identify the members, to contact the members. A lot of times the membership may not have accurate contact information, so it will require some additional digging and research. As far as care plans, you would target creating care plans for 100% of the membership, including your unable to reaches. This way, by some chance of maybe you can outreach them by phone, they still may have a contact, via mail. There could be something forwarded where they still get a care plan and could generate some additional participation. For the interdisciplinary care team, you would have a registered nurse for levels 1 and 2, but include a physician for level 3 and complex case management. For transition outreach, you may want to do up to 4 attempts within 5 business days, with the emphasis on the first 48 hours. Research does show that contacting the member within the first 2 days after discharge does have the largest impact on reducing readmission. Regarding reporting, the reporting and analysis of the data is a central derivative of the program. Whether a vendor is used or not will impact the level of reporting required. At minimum, there is a significant amount of slicing and dicing of many data points. To manage the program daily, you need to monitor all turnaround times and activities due for timeliness, the number of planned and unplanned transitions, and the number of health risk assessments completed. On a monthly basis, review of potential at-risk members for unplanned emergency room or hospitalizations, review of turnaround times to ensure there are no gaps in process, and that all timeframes have been satisfied. The overall program should be measured on the percentage of engagement, a marked reduction in planned or unplanned emergency room and inpatient stays, the impact of overall dollars spent on claims, as well as member satisfaction. Regarding results, this slide just demonstrates the per member per month cost of members that have responded to an initial health risk assessment and their associated stratification. The reason SNP is lower than Medicare Advantage in this slide is that this is what we see for medical costs. Adding back in the pharmacy costs raises Medicare Advantage by approximately $150 and SNP by about $300. This is also client-specific data, which may not apply to all environments. This is intended to be an example of our health risk assessment risk stratification from high to low risk rather than absolute dollar values.
Thanks, Fred. There's just so many moving parts to everything and so many changes with CMS and NCQA. I guess a couple of things that jumped out at me. One is that a strong partner can really, really help extend or expand the capabilities of a health plan, and certainly to help a health plan stay on top of the changing compliance environment, as well as the specific state regulatory requirements as well. A couple of questions that we have for you. One is, let's talk a little bit more about HRAs. From a SNP or from a CMS or an NCQA requirement, is there an industry standard HRA tool that they look for when it's approved, or is there flexibility in that HRA tool?
There's definitely flexibility. There is not, again, a standard, but you want to make sure that it is able to capture, that it serves several purposes. You don't want an HRA to be so lengthy the members are not willing to complete it. Sometimes you want to have it completed telephonically, or other times completed by mail. In order to be able to garner the data that you need from it, again, it does not have to be extremely complex. Some HRAs could be 200 questions that takes several hours to complete. Obviously, something like that, yes, you may get a lot of great information, but as far as what the useful information is, it's going to be minimal. There are certain core things we're looking for in an HRA that'll help drive our stratification process, as well as keep the members engaged and willing to participate. So again, to answer the question, no, there's not a standard form. You do have the flexibility, and sometimes it's good to experiment between a shorter version and a longer version to ensure you're getting what you need to stratify, and also keeping the members engaged.
Okay, very good. And from a health integrated experience perspective, what are you seeing as a benchmark for like the right time or the right length of will a member be on the phone for 3 minutes or answering questions, or 5 minutes asking questions? Do we see an average of what's most effective?
The average, it all depends how you set the call up. If you go in saying this might take a couple of hours, chances are they're going to be thanks but no thanks. You could also break it up. I'd say average, about 30 minutes is the greatest attention span. And again, it depends on the population. If you're dealing with, someone who's more in the Medicare age range, they may be more apt to spend additional time on the phone than someone younger that, got a shorter attention span. So, but I'd say we average about 30 minutes is typical.
Okay, great. And that kind of segues into the next question that we have, which is on stratification. I know that you mentioned in your presentation stratifying into low, medium, and high. Does CMS or NCQA specify the levels of stratification, or is there flexibility there as well?
There is flexibility in there as well, which again is one of the great things about the SNP product is with a lot of it, NCQA basically measures what you document. So you can set that. So you could just have a low and a high. Some plans may have 4 levels. It all depends how your staffing structure is set up and how you want to break out your membership. Essentially with complex case management, it can be considered 4 levels, your low, medium, and high, and then complex case management. But typically it's going to be 2 to 3.
Okay. All right, very good. And that segues actually into another question that was asked about the flexibility and time frames. While there is flexibility in the time frames, once you've committed, is that what you're held to? And it sounds like you're confirming that that's exactly the case.
Most definitely. That's what you're held to. And again, it's a very fine balance when you're establishing those because, again, the shorter the time frames, you're going to see a better result. So your return on investments and everything else, your readmission rates, all of that will be much improved with the shorter time frames. However, you do have to balance that with your staffing needs and what levels of licensure you have doing what. So again, the longer the time frames, the easier it is to schedule out if you have a larger population. If you have a small population, then it doesn't matter so much. I would recommend keeping the shortest time frames right from the gate. But in a larger population, especially if you're just starting out in the SNP program, it might be better to use some of the established longer time frames and grow that year over year.
Okay. Okay. Another question, and this actually goes back to the HRA, so I'm going to go back to that for a second. Question is, are there HRA templates or products that you might be able to recommend?
That's one of, there are products out there. However, organizations, like to tend to like to do those themselves because that is what tends to differentiate yourself from another program and what your results might be. Between the initial HRA and the stratification, a lot of times people might refer to that as the secret sauce. That's going to be what differentiates one company over the next. So while there may be templates out there, there are specific vendors that do nothing but HRAs, and they may have their own templates to use. That's something you may want to experiment with to, customize it for your specific needs and what your goals of the plan are.
Good point, and that's something that we certainly do here at Health Integrated, which is very population-specific HRAs, again, where a partner might be really helpful. Okay, so next question. Do you include problems, patient-rated outcome measures, and use computer to capture information? I think it's problems.
I'm not sure I fully understand the first part of that, but as far as capturing the information, yes, we do log everything into our system. We have two different ways of stratifying. So the initial is based on all the data. It's all done through algorithms and formulas, and it's a systematic initial risk assessment. However, we do take that and have the clinical team, the interdisciplinary care team, look at it because not every peg is going to fit into every square. So you're going to want to use that clinical expertise to make those individual assessments and a judgment, but we definitely do use a system or a program to set the initial.
Okay, very good. Next question about the interdisciplinary care team. You mentioned that it is really beneficial to have a member provider participate. Is there any requirement around that, and what has is it? Do you hear evidence that it's common for that to happen, and how do we make more of that happen as we get to more patient-centric and truly coordinated care?
The requirement is to make sure that the member, that the offer is made to the member, that the invite is extended, and that you have a means to include them in the process. Same with the provider. A lot of times, the way that the member does participate or their usual care practitioner participates is when the draft care plan is sent to them, they may add their own commentary and send it back to us, and then we use that when we're reviewing it in the interdisciplinary care team. So that is a form of participation, even though it's not live during the meetings. It would be a great feature to have a higher involvement with that because, again, this is the members' health and the members' care. So to keep them as included and involved, there's a better buy-in that they're working to improve their health status as best as possible as well.
Right, and it really helps with the building more of a self-efficacy as well.
Exactly.
Helping them get on the road to managing their health better. Okay, let's see, next question. Everybody's favorite, SNP 4.
Care transition.
Care transition. We know from the reports and commentary and other conferences that this one is a particularly challenging point for people to achieve good scores on audit. So thoughts, suggestions, what is the best way to document the steps that you're taking in care transition to truly be effective on an audit?
The key is to know what's being measured, and to start there. So whether you have a system that's robust and automatically tracks everything that's needed, or if you're using an Excel spreadsheet to track everything, it's doable either way. No matter which way you go, it requires a lot of oversight and maintenance. But the key is to first identify exactly what areas you need to measure and capture, and include those in whatever means you're using, whether, like I said, it's Excel or you build it into a program. It is the most challenging just in all aspects of it, but it's also the most important. The addition of outpatient and ambulatory surgical centers for 2013, I did stress it during the presentation, but I can't stress it enough. That's that is a pretty major change. You know, your inpatient and acute stays, you know, are one percentage, but your outpatient is significantly higher.
Right.
The one business day to that care transition exists as well, so it puts a much larger pressure on the workload, which is going to cause most plans to have to reevaluate, you know, their acuity levels for their staff and caseload requirements and everything else. And like I said in the presentation, also the communication between the utilization management department, because it's imperative as soon as you're notified of that authorization request that the care manager gets involved. And we probably will see a much bigger impact on the membership and their the effectiveness of the programs by doing this.
Mm-hmm.
Just be prepared for that level of change.
Mm-hmm. That is a significant change.
Yes.
Wow. Okay, greatly increasing manpower as well. So we talked a lot about workflow throughout this as well. So one of the questions with respect to making sure that your system is configurable, it sounds like when we were looking at it, we basically deconstructed the CMS audit and reporting process to build a system that would address all of those. Is that a recommendation that you have to, you know, a good way to back into your requirements?
Always. Because honestly, if you're not able to meet the requirements
mm-hmm.
and you have the ability, you know, to do something, if you're purchasing a new system or moving to a new system,
mm-hmm.
it would be like, you know, literally shooting yourself in the foot if you don't take advantage of that. And that was the number one thing, to make sure we knew exactly, you know, what needed to be measured, how it needed to be measured and reported,
mm-hmm.
and built that into the workflows so we have accurate reporting, easy reporting, because again, a lot of what the requirements are can be very cumbersome to manage, to collect the data,
mm-hmm.
you know, unless you specifically design the system to do that.
Mm-hmm.
So if you have that opportunity, I highly, highly recommend that.
Okay, great. Another question around HRA. Is there any requirement on how a member responds? So in other words, can a member respond, let's see, rather than asking verbally, can a patient enter the information themselves into a computer-generated HRA? Is that acceptable?
Of course. There's a wide variety of methods of doing it, depending on how your plan is set up or how if you have an HRA vendor, how they're set up. So they could either do it telephonically, by mail, or through an online process, or a combination through both. You know, they may send it by mail, have completed, and then you may do an outreach and be on the phone and fully complete it with them. Either way, you know, it's a starting point for the process, but once a care manager does reach that member, they're going to want to do a more in-depth care coordination assessment, or some places call it an ICNA, an initial care needs assessment.
Okay. Okay, good. A little bit about care plans.
Mm-hmm.
So we know that, you know, health literacy is a very important issue, and, you know, obviously CMS has requirements around reading levels and the like. So speak to a little bit about that, and then the additional piece of that is also required and ties into the HRA. If a member does not return or wants to contact a care navigator and are considered low-level participants, so level 1, what should that plan of care include? And talk to that in terms of care literacy as well.
Sure. And it is a challenge because it is one care plan that's being used for the member and for their usual care practitioner, their PCP, as well as any facility they may attend. So as far as the literacy level, it is going to be gauged a little more toward the providers of service versus the member, with the exception of the member goals, because those should be as close to the member's words as possible, so they understand what their goals are. They identify what their barriers or other conflicts might be in reaching those goals. So when it comes to the care plan, that part is going to be, you know, at a different level, literacy level, than, you know, the rest of the care plan. The rest of the care plan, you want to make sure, you know, any diagnosis, any information is very specific and very, direct, so there's no misunderstanding with the providers.
Okay, very good. And SNP4 again has gotten a lot of attention, which is great. The questions are coming in, so keep them coming. Can you review the requirement from the inpatient setting again regarding transition of care?
It's basically any transition of care from your usual setting to another setting. So if it's an admission, whether it's into acute care setting, SNF, or any other inpatient type setting, the requirement is to produce a care plan to the receiving setting within 1 business day of notification. Now, there are times that the member may discharge prior to the notification. So, of course, in that case, that someone would, destroy that requirement. You're not going to want to send a, care plan, because then you also need to send an alert advising that they've discharged. So, there could be a situation where they would get a discharge alert before the admission alert, so you don't want to do that. But that is a requirement within 1 business day of any transition from their usual care setting.
Okay. All right, very good. And then let's see, the last set of questions here looks like it's around changing or the evolving CMS requirements. There's one that's very specific about SNP model care audit protocols that were referenced in the HPMS memo dated January 2013. We may need to, unless you're familiar with that off the top of your head, we may need to respond to that question private with an individual email.
Yes.
Okay. But the other question is much broader than that. So do you have any recommendations on how to stay ahead of the changing CMS and NCQA requirements, or even any thoughts on what the next set of changes might be?
It's tough to stay ahead of it, because what typically happens, as example, NCQA released their 2013 changes in guidelines mid-year this year. So the key is to find that as early as possible, because the audit is basically, say, October 15th is when audits are due for submission. The look-back period is 6 months. So obviously, depending on the changes, like there were significant changes here, you're not going to be able to satisfy that for the entire look-back period. The great thing about NCQA is, as long as you have the documented process in place and have it set up going forward, I don't want to say they're more lenient, but they do accept that. Understandably, if something doesn't get published until June and the look back is April, you can't necessarily be accountable for it. So it is a little difficult to stay ahead of the game with that, but staying in touch, being on the NCQA site almost daily does help. Because there's always information out there, so that's the key. Don't wait to hear from them. It's always good just to stay in contact. Okay,
very good. Any words of advice on cure periods?
On what?
Cure period?
No, it's
listen carefully, respond quickly.
Yeah, that's listening and just again, like you said, responding quickly, keeping people involved is going to be the key. If it's again a low touch plan and things are happening that you're not aware of, it's going to be more difficult to stay on top of things.
Okay, very good. And it looks like we are out of question and actually at about the end of time. So thank you so very much, Fred. Really helpful, really insightful information. And to everyone on the phone, all of our callers and attendees, thank you for joining us today as well. We really appreciate your participation. Also, please join us again next month. Dr. Sam Toney, who is the Chief Medical Officer here at Health Integrated, will be presenting innovative care management strategies, and that will take place on Wednesday, October 23rd at 2 p.m. Eastern. So please watch your emails on our website for registration information, as well as watching your emails for the link to today's webinar and future access there. And with that, this concludes today's webinar. Thank you and have a good afternoon.